EM board bombs.
Hey, old fellow. Welcome back to EM Board Bombs.
Good met.
Good met. Oh, we're back. EM Board Bombs, come for the STEM, stay for the content. Bet you weren't expecting that on a afternoon or morning, whenever you're listening to, or morrow, as they say. As you can tell, we have a medieval theme to our podcast today. You'll discover in the STEM in a second. For each 10 to 15 minute episode, we give you high yield emergency medicine board content for hashtag EM Life, hashtag boards. I have the amazing, incredible Dr. Dame Marlena Masiski-Kuhn. I don't know what other titles they use.
And but a fair maiden.
Yeah, Baroness.
Nice.
Thank you for stepping out of your feudal castle to help us with this STEM today.
I am happy.
If there are some like hidden Renaissance nerds out there that are like secret subscribers to EM Board Bombs, they're probably loving this right now. They're going to bookmark this episode.
Right. We did this for you.
Ildefot couldn't handle medieval world, so he's not with us today. He's currently at Comic-Con instead. So let's dive into this. We got a 25-year-old male presenting to the ED with complaints of vomiting and fatigue. He states he's been worsening over the past 3 days, and he states he's been urinating more too. You ask him if there's blood in his urine. Typical question, right? You would expect a typical answer. He replies no, but that he has been urinating into a gallon milk jug to minimize the amount of flushing or stress put on the septic system. He then asks the nurse, "Where be the privies?" He is wearing a muffin cap, hose, gown, and a large belt underneath a hooded cloak. You ask what he does for a living. He says he's a Rennie. You ask him what that means. He says he travels with the Renaissance Fair. He states he has not had his prescriptions filled in weeks since leaving home. And he states he has some history of some, quote, kidney problems, that his pediatrician told him that he requires him to take steroids on the reg. He appears tan in complexion, and the patient states he has not been manning the trebuchet as normal outside. Which of the following electrolyte changes would you expect to see in this patient? Choice A, hyponatremia. Choice B, hyperglycemia. Choice C, hypokalemia. Choice D, hypercalcemia. Dr. Masiski-Kuhn, before you tell us the correct answer, why don't you tell us about EM Rapid Bombs? We're in board season right now.
Yeah, EM Rapid Bombs may or may not be sent via trebuchet to your podcast subscribing
Carrier
app
pigeon
on your phone. Yeah. A couple times a week, you get a short podcast, very focused, and we have almost 400 episodes. They're counting. It's definitely a great way for you to prepare for your boards and for real life.
Check it out. EM Rapid Bombs. Go to emboardbombs.com. It'll be helpful if we gave you the website.
Yeah, you can find it on the
Check
website, on our website, on all
website.
our social media profiles.
All the socials and the website. Check it out. All right. What is the correct answer here as we dive into this topic?
The correct answer for the electrolyte change you would expect to see in this patient is hyponatremia.
Big time. Hyponatremia. So we're talking about obviously some type of version of adrenal insufficiency. Now, we need to clarify. Please do not turn off your podcast. Please stop. Don't leave. There are a lot of people that probably, checked out the title of this podcast and said, yeah, no thanks, bro. I'm just going to miss this. I'm going to take the L. There's a second group of people that probably checked out the episode and said, you know what, I'm going to give this a shot here. I'm going to listen to the STEM. I'm going to come for the STEMs. I'm not sure I'm going to stay for the content. And then the minute Marlena utters these next 3 words, we're going to lose a lot of people. We want to promise you that this is literally just 30 seconds of some really nerdy stuff, not as nerdy as the Ren Fair. And we promise we're going to delve into what's relevant as an emergency doctor. We promise we're not going full IM on you here.
No, definitely not.
Never go full nerd. We promise we're not doing that.
No, I'm not wearing my white coat. We're not drawing on a whiteboard. I'm just going to really quickly tell you about the normal HPA
Get it over with. Let's
axis.
go. Let's get over with.
Don't
oh my
leave.
God. Oh, no.
Don't leave.
We just had a drop.
I'm sorry. Really fast. I'm going to say this so quickly. The hypothalamus stimulates the pituitary with CRH, stimulates the adrenals with ACTH. The adrenals release cortisol, which is a glucocorticoid, and sends negative feedback back to the hypothalamus. It's a simple loop. You shouldn't need to draw it. I'm not going to. That's it. The adrenal gland also produces aldosterone.
I like how you slipped in at the end there.
P.S.
By the way.
Some just because you want to be familiar with this language, I will also cover this quickly, but there's primary adrenal insufficiency. That's the problem with the adrenals themselves. So you have a lack of production of hormones by the adrenals. This is most commonly due to Addison's disease, which is autoimmune. And those patients are going to lack the glucocorticoids and the mineralocorticoids. So no cortisol, no aldosterone. Then there's secondary, which is due to impairment of the hypothalamus or pituitary gland, causing a result in lack of ACTH. That's commonly due to pituitary adenomas. And then the last one is tertiary. That's due to a lack of CRH. That's the type that you most often see and is due to abrupt cessation of chronic steroid use. So if you're having to choose the ICD diagnosis, if you want to, you can be that specific, or just remember that.
Just cite our podcast.
We're done with
We're done.
the nerdy stuff.
So
get the
when do you most
leg.
commonly see turkey leg? Hey, turkey legs are good.
I know that's the only reason to go to a Renaissance fair. I know.
Yeah, do also do that at Disney. Anyway, we're not sponsored by Disney, by the way. So the diagnosis of Addison's disease, primary adrenal insufficiency, as they call it technically, is unfortunately often diagnosed in the ED. So the problem is people come in adrenal crisis. That's the most common scenario you're going to see as an emergency doctor. And it's going to be some type of physiologic stressor, GI illness, infection, recent surgery, trauma. This is the classic board test question. If you're a med student, this is that test question they give you in terms of, hey, they just had surgery done. They're on steroids. Guess what's going to happen to them? Boom, done, bad stuff. Mm-hmm. Same with your EM boards or IM boards. It doesn't really matter. This is always on some test question for everybody, every medical specialty, because it has to do with people on chronic steroids or adrenal issues, and they come in and they have a stress and no one ever upped their steroid dose, and now they're in big time crisis mode. So what happens here is Addison's disease patients, they present in the second or third decade of life. They have these non-specific symptoms. None of them are helpful. It's fatigue, weakness, whatever, postural hypotension, orthostatic stuff. They might mention salt craving, and they may or may not have hyperpigmentation. Now, the hyperpigmentation, I think, is, I would say almost every doctor knows that word. When you say hyperpigmentation, every single doctor that went to medical school, and finished medical school, I should say, will say that, oh yeah, that has to do with some adrenal thing, right? Or that's an adrenal issue. Everyone knows that, thankfully. So that is the standout point here. You're not going to forget that. If you see that test question, just know, oh yeah, Addison's, piece of cake. So they're probably not going to mention that word. We gave it to you because we were asking a secondary question, but just know that this occurs in almost all patients, sun-exposed areas. And since this is usually ubiquitous and a standout feature, remembering this is critical for the test. Now, in real life, you might dismiss this for the patient just being tan, which is difficult, right? So in the setting of a lot of electrolyte issues and history maybe being on steroids, that should stand out to you as not just being tan. That's actually a pathology. Now, what to you, Marlena, stands out the most in terms of their presentation? Because really, their symptoms don't help at all, except for the hyperpigmentation. What is going to stand out the most? Because there's a lot of non-specific nonsense that does not help you at all.
For sure. So I think the most helpful part are the electrolyte abnormalities, and it's an easy pattern to recognize, and it's a pattern that's specific to this. So hyponatremia, hyperkalemia, hyperchloremia, acidosis, and hypoglycemia.
Hypoglycemia, yeah, low glucose. Which you said, I'm just enunciating. I'm your hype man. I'm your hype man. I don't know what a hype man was called in the Renaissance. I guess a town caller or something. Town crier. Harry, hypoglycemia.
It is hypoglycemia. Yeah, so
eat the tree bark root for fresh tree bark root. All right. And of course, the hyperpigmentation, and especially the groin and axillary areas, because those areas normally shouldn't tan, right? So if you have tan there, that's concerning. So let's get through one more nerdy point here. We just have to mention it just because you're probably sitting there wondering, I wonder what labs I could order that could diagnose this, like a CRP, ESR, right? So tell us the diagnosis of Addison's or adrenal insufficiency in the ED.
Yeah, so it's something that you're not going to do because it's time intensive and it's not feasible in the ED, but the gold standard for diagnosis is an ACTH stimulation
Oh
test.
boy.
Yeah. So some people will talk about random cortisol. Random cortisol is not a diagnostic test,
Hmm.
but it may have some utility in a patient who has not been diagnosed. If the random level is less than 10, then a diagnosis is more likely. So you can draw it, and then if it comes back at like 35, you're probably
Hmm.
wrong. In real life, you're never going to have a firm diagnosis in a patient that has no existing one, except for hyperpigmentation, electrolyte combinations, and realistically, the fact that they're on chronic steroids that I have stopped taking.
Right, for sure. Now, let's go over the treatment of a patient not in crisis. So, what you're going to do here is if they have a history of it, of Addison's or adrenal insufficiency, you're going to correct electrolytes, and you're probably going to admit these patients anyway because they're going to go home and then they're going to go in crisis. Because
Yeah.
if they're teetering on the edge and they're there for something related, the derangements can be moderate, but the fact is that they're going to veer into that crisis, especially if they have hyponatremia, which is the most sensitive electrolyte finding. Now, if they have a diagnosis of adrenal insufficiency and you're treating them for something else, you have to remember to stress dose steroids.
Hmm.
Now, the treatment of adrenal insufficiency is individualized. Every patient has to talk to their endocrinologist or primary care doctor about what dose of steroid they're on. Most patients will need some combination of a glucocorticoid like hydrocortisone with fludrocortisone, mineralocorticoid. It doesn't matter. You don't have to memorize that ever. Don't worry about that. Actually, most patients, I've dealt with this in the past, most of them are very educated on
Yeah.
asking you, hey, my endocrinologist told me to up this when I have this problem, when I'm having diarrhea, I have a GI illness, or let's say you're sending me home for pneumonia treatment or something like that. I don't know. And their endocrinologist will tell them with written instructions, do this for your steroids at home when you have this problem going on. So most people are pretty good about that. It's the patients that have a sudden change and a stress in their life, or the doctor forgot to tell them to increase their steroid dose. Those are the patients you're going to be dealing with in the ED. And so let's talk about those patients for adrenal crisis. What are you
Yeah.
doing for these patients? What is the classic story for these patients? This is going to be by far the most ED relevant. I wish there was a town crier that could ring a little bell right now, or ring the, it's like when you ring the town central bell or the church bell when they were under
Yeah.
attack. This is what we need to ring right now to get everyone's attention. Man the
Yeah.
walls, man the trebuchets.
Man the walls. Present to your trebuchet stations.
Yes, your trebuchet stations. We learned all about trebuchets as we were researching this podcast. I was shocked to learn that there is a Reddit following on trebuchets that Marlena talked to me about.
Yeah. Don't call it a catapult.
Yeah, the people get very upset about these things. These are the big problems the world is facing right now. Is the difference between a trebuchet and a catapult. One is infinitely more cool to say. One is infinitely more cool to build. Yeah, if you had to compare our podcast to other podcasts, we are not a trebuchet. we we are a highly functional catapult, but it's an automatic firing catapult. It reloads by itself. It reloads. It's a very sophisticated catapult, but we're certainly not a trebuchet.
No,
Sorry to
this is not
disappoint
trebuchet
people.
level.
Yeah.
It's a great catapult, though. It does its job. So adrenal crisis. These are the patients that are going to look bad. They're going to be hypotensive, and it's not responding to your standard therapies like IV fluids or even pressors. And you don't really have any other cause for why they wouldn't be responding. You need to think about adrenal crisis. Sure, it seems like a zebra, but when you think about it, it's not really. There's a lot of patients on chronic steroids for a number of different things. And when a physiologic stressor hits them, their body's already off balance. Cortisol is what makes our vascular tone respond to endogenous vasopressors. So giving them vasopressors isn't going to help as much as you would expect it to because they don't have the secret ingredient of cortisol.
Special sauce.
The special sauce, the special cortisauce.
Yeah.
A patient can be, presenting with acute on chronic adrenal insufficiency or de novo, so you may not know that they have this history. Like we mentioned, the common question is to present a patient who stopped recent kind of long-term high-dose steroid therapy without a taper, or a patient with a history of pituitary disorder, and in the patient with the history we talked about before. I do want to mention, it's not a patient who took a 3 days of 5
Correct.
milligrams of prednisone.
Absolutely.
That's not enough. It's got to be a little more than that.
Yeah, really, even less than 7 days. They're coming out now saying burst therapies for 5 to 7 days are totally safe to do. You don't have to do these big tapers anymore. So you're absolutely right. I'm glad you mentioned that. Yeah, tapers for unless you're doing like doses over 100 milligrams of prednisone a day or something crazy. The standard prednisone burst for COPD or asthma exacerbations, these are not included in these patients. Absolutely right. So why don't we talk about the dose of the hydrocortisone you're doing, the stress dose steroids here? Thankfully, it's the same dose pretty much as your, complicated septic shock patients that are not responding to Levophed.
Right. So the dose there is hydrocortisone, usually 100 milligrams IV. That's because once you get doses above 50 IV, hydrocortisone is also going to have some mineralocorticoid activity in addition to the glucocorticoid activity. So that's why 100 is where you want to be. And that should begin to show a clinical effect in less than an hour. So it's pretty quick. Remember that you also need to resuscitate the patient and treat them for the underlying trigger for the crisis. So if they're presenting in septic shock, like do the sepsis things also, like with a lot of other things we talk about.
What are all those protocols? Yeah, it's important to understand some of these key lab values. So why don't you rehash this in terms of what our lab values are expected here? And then also, what are you doing as you're taking care of these patients? What's the one you need to check the most probably?
Right. So, we mentioned that an easy way to identify this, maybe like the quickest and easiest way to identify it, is with the lab pattern of values, the hyponatremia, the hyperkalemia, and the hypoglycemia. After you give the patient the hydrocortisone as a treatment, one of the next step is going to be managing the metabolic derangements. And really what's important are the point of care glucose checks to follow your hypoglycemia. That's often going to be the first metabolic derangement you identify, because that finger stick comes back faster than your renal panel. But you're also going to need to be checking that more frequently. They may require continuous IV dextrose depending on the severity of their presentation.
Absolutely, yeah. So remember those key electrolyte abnormalities. Remember the stress dose steroids. Really, any patient that you're treating for septic shock that is unresponsive or not responding well to norepinephrine or even vasopressin, if you start that. If you're pulling up vasopressin, I say this all the time to resident students. If you're reaching for vasopressin or you're increasing the dose dramatically of norepinephrine, give stress dose steroids automatically. Doesn't really matter about their steroid history. You're giving stress dose steroids. So this is just that one extra step of recognizing, oh, okay, they may have a chronic history of being on steroids and they're not optimally controlled. Cool. So I think that's really a good wrap up here. Just know the adrenal crisis, know resistant hypotensive sick patients, know about increasing their steroid dose in stressful situations. Those are the main questions you're going to get. And then just the electrolyte abnormalities for this adrenal crisis is all you need to know with hyperpigmentation. That's really about it. I think we've done a great service to the men and women of our Renaissance fairs across the United States, across the world. Next, we'll be covering Comic-Con. Iltafat is live at Comic-Con, otherwise known as ASAP. Just kidding. Anyway, we miss him. He's in our hearts, and hopefully we'll get a report from him soon. Marlene, you got anything else?
No. I wish I knew how to say goodbye in Renaissance language, but
yeah, we didn't look that up. We didn't get that far. We were looking up so many phrases.
Someone tweet me.
Someone will respond very angrily, probably too. Drop that 5-star Apple review if you want. You can check us out again on any podcast streaming service, and check out our EM Rapid Bombs podcast. Boards are coming up. Also, the ITE in February for residents. If you are a resident, you need to start preparing for that. And instead of cramming in January and all of February, why don't you just start drip learning? That's the best thing ever. Learn just one episode a day, one question a day, and you can check us out at emboardbombs.com. Thanks again. We will see you next time.